So, I think it's 8 p.m. The meeting is live on YouTube also. So, can we start?
Okay by me.
Dr. Menon?
Yes, you can start. You can start.
Yes. Well, friends, welcome to the first session of the Dr. Sambit Mohanty Memorial Lectures. We lost Sambit Mohanty. We are in great sorrow. We start these lectures. Dr. Sambit Mohanty, I mean, they say that it takes a century to create a person like Dr. Sambit Mohanty. He was a nationally and internationally acclaimed and American board certified pathologist, and with 12 gold medals and record of honors during his medical college career from Bhubaneswar. And he took his MD from PGI Chandigarh and Beth Israel Deaconess Medical Center at Harvard and New York University with the US board certification. He was a recipient of American Molecular Pathology and CAP Travel Awards. And he was also a recipient of Strobel Oripson Award thrice during his residency in the US. And along with that, he did clinical fellowships, oncological, surgical, and women's health, urological, digital, and molecular pathology from centers like Memorial Sloan Kettering Cancer Center of University of Pittsburgh and Siddharth Sinai Medical Center. He had book chapters in 5 books in pathology and informatics and artificial intelligence. He was a CAP inspector as well. A very, very active member. And he is we really remember him. And recently he organized a conference at Bhubaneswar in collaboration with GUPS, United Urinary Pathology Society from USA, and it was a world-class association or conference. We dedicate the first lecture to his memory. The first lecture will be moderated by Dr. Santosh Menon from Tata Memorial Hospital. Over to you, Dr. Santosh.
I think Anandi wanted to speak a bit. Yeah, Anandi, you can take over.
Yes.
Dr. Anandi?
Anandi, are you there?
Yes, yes, actually, I just, being a student of Dr. Mohanty, what I just had a few lines to say that what set him apart was not just his expertise, but rather his extraordinary dedication to nurturing young minds. And many of us were very fortunate to come under his wings. So today, we wanted to celebrate this incredible legacy that he left behind, his testament to the power of education. So today we are commencing our first lecture, and we are also very deeply grateful to all the eminent international and national faculty who have come forward to help us honor his remarkable contribution to education and pathology. So that's the line. So Dr. Menon, you can carry on.
Thank you, Anandi, and thank you, Dr. Bedi. Before I welcome Dr. Anku Sangwar, who is going to speak today on bladder tumors, I would just like to take an opportunity to remember my teacher, Dr. Sambit Mohanty. When I joined PJ, he was a senior resident, and my first steps, baby steps in pathology were nurtured by Dr. Mohanty, and as has been already been spoken by Anandi, He was an excellent teacher. He had that zeal and enthusiasm to teach all in one who came across, and it touched everyone's life in a manner that everybody would remember him very fondly. With that, I would like to introduce Dr. Ankur Sangoi, who has kindly agreed to give the first lecture. Dr. Sangoi is the professor of pathology at Stanford University, and his focus is on genitourinary pathology, and his main research interests are focused on disease of bladder, kidney, and testis. He has prior experience as community pathologist and has helped tailor lectures and teaching to more general audience. And I think he enjoys teaching a lot. I have been fortunate enough to hear a couple of his lectures, and I've already thoroughly enjoyed his lectures throughout. He is also a avid publisher with more than 100 peer-reviewed publications, and is also on the editorial board of several major surgical pathology journals. Over to you, Dr. Sangoi, and we look forward to your great lecture.
Great. Thank you, everyone, for the invitation. And let me see. Share one. Okay, hopefully you can hear me now.
Yes.
Okay, sorry about that. Welcome, and thank you for the invitation, and it's a great honor to be able to give the introductory lectures for this series, and we have a great lineup of all-star GU pathologists, so please continue to log on and register. So with that, I will begin. I just want to highlight, obviously, this is a tribute to Dr. Mohanty, or Bhai. I used to call him, he's a couple years older than me, so out of respect, we'd obviously still call him Bhai. But this is a picture from Florence at the ECP Pathology Conference last year. And just he was the kind of person that you met, you maybe either met him for maybe an hour, you felt like you knew him for 5 years. He had that kind of ability to peer into your soul and give you that warmth and recognition. It just was something I have never met in anyone I've ever come across. So that's something I'll always remember. So, all right. So today I'm going to be talking about the pathologic staging of bladder cancer, some updates, controversies, and guidelines. So in brief, the staging of bladder cancer, as many of you, and then on our audience, we have some students, some more experienced people. So I'll try to, is more tailored toward general audience, but I do have some higher level material here as well. But, in brief, the staging of bladder cancer, with many people are familiar with, ranging from non-invasive all the way up into T4 invasion into other structures. That's sort of a nice picture book cartoon, but in practical, reality, what we see, it's not always that straightforward. And I'll kind of highlight some of these. So, non-invasive, so PTIS would be an in situ flat lesion. PTA would be non-invasive papillary. PT1 invading anywhere from the urothelium top into the lamina propria, so that's a wide spectrum there. PT2 is into the A and B are subdivided into the muscularis propria, inner and outer halves. 3A and 3B for bladder cancer staging are, if it's microscopic, it's 3A. If the grosser can actually see the tumor invading into the fat, it would be 3B if you can grossly see it into the fat, and 3A if it's microscopic. So bladder cancer staging, the PT status, and you'll hear me throughout this talk say, PT1, PT2. Just remember that that's actually technically reserved for the resection specimens. So in my practice, I don't actually stage biopsies and TURBTs, but I still think it's helpful to consider the PT landmarks for proper path reporting and staging sign out. In terms of grading, I get this question asked quite a bit. It's basically, at least for me, I can probably count the number of times I've done "quote unquote" low grade invasion. I think by far, as long as you're confirmed that's invasion, and I think clinically that's the most important point. I'm effectively at high grade. There are some rare scenarios where you have a high grade non-invasive and a low grade invasive, or vice versa, but that's pretty uncommon. I would spend most of your attention as just focusing on invasion and the various landmarks and staging parameters with that, and less so on the grade. And then other helpful clinical informations are if you can get it, hopefully you get that in some of your cases, is the cystoscopic findings, the location within the bladder, and the clinical stage, which often in the reports comes as CT. But as many of the folks do get consults or material from the outside, I know some of that is not always available. So With that, so let's dive right into PT1 bladder cancer, which is defined as invasion into the lamina propria. So some tips, and I'll show some pictures here in a bit, but I just wanted to kind of highlight at least my tips for identifying T1 invasion is most importantly, you have to ensure that you're not dealing with tangential sectioning of the overlying non-invasive papillourothelial carcinoma. I think that's probably the most important thing. Cautery is probably another artifact that can be a little bit challenging. Finding small irregular nests of atypical urothelial cells at the subepithelial base is really helpful. Stromal retraction is very, very helpful. And effectively, that if you see something that looks like lymphovascular invasion, by far it's probably not. Actually, it's actually a great tip that you probably are dealing with LP invasion. And I usually don't pursue IHC on those. So here's a nice example of something that I would consider as not PT1, but a common problem, I would say, more often than actually finding invasion is that excluding the non-invasive is these small irregular nests. And sometimes they can have some tissue, this has a nice tissue crack, artifact kind of splaying the tumor and sort of displacing that into the stroma, but there's really no retraction at all. And it has this sort of displaced look, and it does seemingly connect up into the overlying mucosa. This is something I would just consider as non-invasive, so not PT1. In direct contrast, in this case, you see a nice low power image of a papillourothelial carcinoma, and your eyes are drawn at least to this focus, or maybe another one here on the left, of an irregular rounded nest, which sort of looks like lymphovascular invasion. And some of these, including either single cells and does have some degree of cytologic atypia. This is, no levels needed. To me, this is, no stains, nothing else is needed. This is classic PT1 lamina propria invasion. Some additional tips that you sometimes can also see is what's called paradoxical maturation. And what that means is along the leading edge of the tumor cells get a little bit more eosinophilic cytoplasm. Usually this is not true squamous differentiation. So bladder is a little different in other organs that by default, the cytoplasm is always pink. So I frequently will see people say, oh, that's, you have some aberrant squamous differentiation. And we do have a follow-up lecture that I'll be doing on subtypes, and I'll address some of these issues then. But it really, to do squamous, it requires frank keratinization. It's a morphologic thing. So, but at least in terms of identifying invasion, it's actually quite helpful to find that eosinophilic cytoplasm along the leading edge. And then sometimes you do get some stromal desmoplasia. So here's kind of a nice low power example here. On the left, along the leading edge here, you do have invasive tumor cells with some desmoplasia, but you can see how much pinker these are than the overlying more bluer non-invasive components. So again, this is another helpful clue for lamina propria invasion. But admittedly, sometimes it's really challenging. So in a case like this, you're sort of scanning along and you see this sort of irregular, not necessarily irregular, I should say, kind of a basaloid-looking nests. And you sort of go down on higher power, and just as in a quick look on a busy day, this sort of essentially looks like, these all seemingly connect up to, these have fibroblastic cores, it's non-invasive. However, along the leading edge here, you can actually see some paradoxical maturation, a little bit more atypia, and some stromal retraction that I think are sufficient to pull the trigger and actually call this T1 invasion as is. So that can be quite a challenge sometimes on these cases. So sometimes immunohistochemistry can be helpful. The use of this as a pan-keratin immunostain. And, I don't use this routinely. I more often use it mostly for teaching, if anything. But if I'm really worried about histiocytes in the stroma, or just to identify the sheer number of tumor cells that could potentially be there. But here's a nice example. You have these irregular nests of epithelioid cells with some stromal retraction and some eosinophilia. So this is, again, good for PT1. But I would just urge caution. But I think this is more often used probably erroneously. So here's a nice example that you're just doing the inverse, and you're looking at this. Oh, this looks very classic, like PT1. And I will tell you, I had this case yesterday, and I added this very late because I thought this was a nice example of misclassification as PT1. But then you look at the H&E, you have a papillourothelial cancer, and this is actually all fibrin and inflammation and stroma. There are some degenerative tumor cells in here, but this is actually not invasive at all. This is just free floating. So just be a little bit cautious if you're going to use immunohistochemistry. So let's apply these in an actual, real life setting. So you have a 55-year-old hematuria, posterior bladder wall tumor, and you have an area here that has some degree of stromal retraction that looks like this, and it's pretty good for invasion. So how do we sign these cases out? So here's, I think, a pretty reasonable way to sign this case out. High-grade papillourothelial invading the LP. We always want to document if there is muscular propria present in these specimens for their urologist to determine if the tumor was sampled correctly. But let's take a little bit closer look at this concept of the extent of lamina propria invasion. So the AJCC most recent edition defines, or at least recommends, that there should be an attempt to categorize the PT1 disease in term, but it doesn't necessarily describe how. They do include this concept of so-called microinvasive disease with various definitions that are listed here. You can see some of these numbers with, greatest depth of invasion of 1 millimeter, or MM is muscular mucosa extending to either a depth less than 2 millimeters. And then on the flip side, on the CAP synoptic, if you actually, and many labs are employing the CAP staging, for a lamina propria, even for TURBTs, lamina propria, when you click on this, there's actually a blank that's here, and it actually recommends and says pathologists are encouraged to provide some level of assessment of the LP invasion, but they do not necessarily recommend or offer any kind of insight as to how, whether it's the max depth, the level above or below the MM, just doing something to suggest, to sort of quantify how much LP invasion there is. So let's go back to this case. So I think one potentially reasonable way would be to essentially just measure across that way, and you can see you may not be able to read these numbers, but these are both small foci less than a millimeter. So I think it's pretty reasonable to sign this case out as focally superficially invasive, maybe something descriptively, either numerically as well, less than a millimeter, into the lamina propria invasion. I think that offers the urologist a little bit more insight as to how much invasion you're actually dealing with. So let's look at another case. Similar history, similar location. Now we actually have two foci that light up, one smaller focus here and another focus here of a papillary urothelial carcinoma with some irregularness into the stroma. Pretty classic H&E for a lamina propria invasion. But now, if we were to actually draw a line and measure, if you do this, falls just under the 1 millimeter mark if you happen to make your mark here. But if you just think, well, I think the invasion actually starts here and goes all the way down to this area, that's actually just above the 1 millimeter mark. So they can be a little bit controversial. And in a case like this, would that be focal, non-focal? Is that still microinvasive? Is it truly above the muscular mucosa? So there are some challenges that can occur in sort of stratifying the depth of lamina propria invasion. So let me dive into this just a little bit in terms of subclassification data. There's a lot of data out there on PT1 subclassification, and very recently at the consensus meeting for the ISEP Society, they attempted to kind of discuss this, and it was overwhelmingly recommended that substaging, even for biopsies and TURBT specimens, is recommended. However, there was absolutely no consensus on what methodology you should use. So my goal here is just at least present some of the various methodologies, and hopefully, you can decide if you're going to employ any of these at all, which ones. But it's good to kind of know the landmark. So let me highlight. I think there's three general pots that you can probably use. It's a substage bladder cancer: descriptive, histoanatomic, and micrometric. So descriptive is very simple as a way to sort of, it's a written description. Is it focal? Is it extensive? Is it single? Is it multiple? It's quick, no measurement, nothing at all required. No additional sections or anything. Essentially, it's just an eyeballing, so to speak. But as you can see, it's quite subjective. My focal might not be your focal, so to speak. So that can be a little bit challenging. The histoanatomic actually incorporates a level. It's an anatomical based thing, and essentially the landmarks are the MM, the muscular mucosa, or the vascular plexus. So in that, there's one way to break that down is T1A would be above the MM or the VP. T1B would be below it, and there is actually one modality what actually further stratifies this, similar to almost GI, where you're talking about intramucosal cancer and those concepts. But T1 would be above, T2 would be into, and T1C, T1B would be into, T1C would be below the muscular mucosa or the vascular plexus. So again, it's quite quick. There's no real measurement involved, but this is highly orientation dependent to the specimen, and also there are some variability in the landmarks based on where you are in the bladder for muscular mucosa or the vascular plexus. So what do I mean by that? So here's a nice low power. This is a section of normal bladder. And so this is a full cross section in a cystectomy specimen, just showing you for anatomical purposes, landmarks. So these are nice thick bundles of musculus propria. You have another little satellite one here. these are the bundles of the muscular mucosa, just again below the overlying mucosa in here, and parallel along with that is the VP, or the vascular plexus, and you can see here that essentially goes along in a similar fashion. So it's a kind of a surrogate marker for the MM. And again, here below it's MP, nice thin bundle going across of MM, and some thick wall vessels with the vascular plexus. In the dome, however, you can see here these nice thick bundles of the musculus propria. The musculus mucosa is actually quite hyperplastic. So here it's potentially a borderline as to whether this is actually MM or MP. But up top here, you can actually see how thick the musculus mucosa is actually riding almost underneath the subepithelium in here. So, based on the landmark, it can look actually strikingly different. So here's some probably deeper musculus propria bundles, but then up top, these are actually strikingly thick and hyperplastic, but that's normal. That's what these look like in the dome of hyperplastic musculus mucosa. In the trigone, however, it's almost the inverse. Essentially, all you see is pretty much all muscular mucosa, and there's effectively this is a section of normal bladder, a section essentially no muscular mucosa at all. But we do have is vascular plexus. So you can see why that surrogate anatomical location is there. But you can see how thin this is. So for me, if I have a tumor that's essentially invading a thick muscle bundle and knowing it's in the trigone, it actually changes my diagnostic threshold as to whether I would call this MP invasion or not. So here's a nice, and again, this is an ideal scenario where you have a beautifully oriented on edge where you can actually see it's a papillourothelial carcinoma, and you can actually see the musculus mucosa coming around the bend here, and then there's a little gap here, but you do have, so no MM here, it just happens to not be there, but you do have the vascular plexus in continuity, and then the musculus mucosa comes around again. Again, that's an ideal scenario where you have the muscularis coming across, and when you're assessing for invasion, it makes it very easy to see that you have invasive tumor nest here, and then this is clearly above the level of the musculus mucosa and or the vascular plexus. So other questions that sometimes come up is, can you use fat? You sometimes see fat in TURBT specimens. Can you use fat to sort of help you orient where you are in the bladder? And the short answer is no. We recently did this study looking at a large series of consecutive biopsy and transurethral resection specimens. And here you can see, we'd always sort of at a cystectomy think of fat that's below the MP. So if anything is involving fat, that's got to be something deep, right? Theoretically T3 if you're using a cystectomy concept. But we frequently will see fat come up quite high, even above, within the musculus mucosa, at all layers. It can be both, and it can be essentially all different sites of the bladder. So you cannot use fat as a surrogate marker to help you in terms of anatomical location. And also to remember that the highest you can go on a T2, on a TURBT, is actually invasion into the MP. I do not comment on invasion into the muscularis, beyond the muscularis propria and into fat. And I'll show you an example of what I mean. And then finally, we have this micrometric, and essentially, as the name suggests, you're actually measuring. And I'll explain what this jargon of vocabulary means here. And you can see this is actually quite, time-consuming, obviously, because you're actually taking, either rulers or micrometers, or if you're digital, you can do it that way. So it's quite precise, but and probably less dependent on the orientation, but can take a long, long time. So one method is broken down as either T1M or T1E, and M being microscopic, is what the name suggests, and it's just like a single focus, small little area with a diameter of less than 0.5 millimeters, which is about a 40x objective, or T1E, which is extensive, is essentially above a 0.5 millimeter or multiple foci of small invasion. So that's T1M, T1E. Another one is called ROL, R-O-L, and it stands for this acronym here. And essentially what you do is you add up all the individual diameter foci of tumor. If the sum of, and that's for the entire case. So, and if the sum is greater than or less than or equal to 1 millimeter, that's a ROL 1. A ROL 2 would be essentially more than that. So that's the ROL, in case you're ever reading literature or journals or papers as to various recommendations. A cousin of ROL is the ALICA, and I think that I like this one a little bit better. And essentially, rather than these arbitrary cutoffs, you essentially add up all the individual foci and you just spit out a diameter, a maximum diameter for the entire case. And clinically, though, the important cutoff is about 2.3 is what's been determined. That's actually what's considered like severe or marked invasion for risk for disease progression. So that's the ALICA way to go about doing these. So let's apply these, right? Okay, I've shown you these. Let's apply these in a real life case. So you guys all saw this prior case I showed earlier. So let's dive right in and let's apply this. So here we have this case. If we're looking like this is clearly probably above the muscular mucosa and or vascular plexus. There might be a thin muscle bundle here, but this is above that in any way. And then if we were to measurement, I showed you some of the measurements across earlier. So it's around 0.3 millimeters that way. We're going to use the greatest one. So this is around 0.58. So just clearly under 1. So if we were to use a descriptive, one way to do this is either focal single invasion. If you're going to use histoanatomic, this would be a PT1A. This is above the MM or the VP. If you're going to use micrometric, it would actually be extensive based on the fact that this is above the 0.5 millimeter. So that's kind of a potentially, I would say, I shouldn't say a problem, but something to kind of, it's alarming that something this quote unquote small could be considered as extensive. And if you're going to use either the RAL, this would be a RAL 1 or an ALICA, quite small measure using the 0.58. Let's use the other case that I showed earlier. So you have this papillary urothelial carcinoma, multiple fragments, and here you had 2 discrete foci of invasion. I'm going to focus my attention on this one because this is, I think, more of a problem is to, and this is, in my opinion, the more typical scenario is you get this haphazard array of tumor cells and you have this irregular bend of the muscular mucosa and admixed vessels. Okay, so if we draw our line here of where the muscular mucosa in here, it looks like the tumor is above it. However, if you consider that, well, no, I actually think the muscular mucosa dips down below here. You have tumor here on the other side of this. So in that case, it's potentially beyond the MM. So that can be a challenge and kind of a problem. So that's one aspect. Let's do measurements. It's 0.997 if you happen to draw your line just above that direction, which is just under the 1 millimeter mark. And if you happen to go this way, it's just over that. And if you just again, it's where you draw your marks in the sand, so to speak. And this going across this dimension, the other focus I showed earlier was 1.4 millimeters. So if we're using this case, this would be multifocal, extensive because you had essentially 2 foci of it. Histoanatomic, it's controversial whether this would be a 1B or a 1C. Micrometric, this would be a 1E. And if used, this would be a RAL 2 or an ALICA greater than 2.3, as I showed before. So to me, this kind of makes some sense. So this is a little bit more than what we had before, but just showing you that, there are pros and cons as to the various metrics that you use. So I've shown you, some challenges along the way, including measurement, depth. How about orientation? So here's an example. We don't know where we are. It's a TURBT, and you say, you know what? Okay, so I'm going to draw my measurement this way. If I'm going across to determine those various, if I'm going to happen to use histoanatomic. However, what if that's not the orientation? What if in this specimen, the patient actually came out this way and you draw your orientation like this? Well, your measurements are going to be actually strikingly different. And you say, well, no, you know what? Actually, I don't think that's the orientation. I actually think the orientation is this way, and I'm going to draw it all the way from the top. And you can see how just the same focus has 3 strikingly different measurements going across. So these are some of the challenges that do occur. Some of you may be seeing these types of specimens, we're seeing them here at Stanford and a little bit more now, is these en-bloc resections. Essentially, they're similar to EMRs in the GI tract, where they're essentially lifting up the tumor and resecting it en bloc, and we're actually providing margin assessment with these. But theoretically, this is more optimal for PT1 substaging, and you can see this usually normal. Typically, you get this beautiful orientation, but however, when you cut this up, you don't always get that. So, but there's really limited data on substaging with that. So there's pros and cons as to the various technique that you do use, but I just wanted to kind of highlight that. And at the very end of the session, I'll have some time for questions because I know some questions did pop up in the chat. So, all right, so that's T1. T2, let's dive right in. So as I said earlier, T2 is this, it's a wide spectrum in here. It's a microscopic, is to the inner or outer muscular propria on cystectomy. That's clinically probably less relevant. What's relevant is, did it actually invade the muscle or not? And that's the issue. So I just want to draw your attention to this acronym that you may see in path reports in clinical reports is MIBC. So that stands for muscle invasive bladder cancer. They're talking about MP. It's a clinical term to imply that the carcinoma has invaded the muscular propria. But importantly, in our path report, just because the clinicians use muscle, we should not be doing that. You really, to avoid confusion with muscular mucosa, you always want to include the suffix. The prefix. You cannot just say the tumor invades muscularis. That is totally, you're setting yourself up for failure and probably for the patient as well, because it's quite confusing, because the clinicians typically mean that implies MP invasion, when in pathwise, you may be thinking that this is actually MM invasion. So you want to be very clear as to whether you're talking about MP or MM invasion. And typically, if you're not going to substratify, depending on which tool you use, really it's the MP that's all that's important. And then some people do use detrusor muscle. I think that's legitimate, fine. That's probably geographically and probably worldwide where you use that term. In my practice, I don't use that. I just say MP, but I think that's totally legitimate, and most of the urologists do understand that that's what they mean. So how about some tips? How do we identify MP invasion? So what that means, it's essentially invasion beyond the lamina propria muscularis mucosa directly into the MP in a beautifully oriented specimen. That's not always the case. Sometimes you just get the bottom of this, or fragmentation. True LVI deposits in the MP, either at cystectomy or at muscularis or at TURBTs, doesn't count. Just like in GI tract, you have a skip lesion, it needs to be a direct invasion. A skip lesion in the MP doesn't count. I'll show you an example of what I mean by this 3/4 rule. In my opinion, and I find that actually quite helpful and sufficient to call MP invasion. There's another concept of what essentially a chewed up phenomenon, where the muscle is essentially shredded, and all you see these little ghost wisp outlines of muscle, or you're not seeing the background thick muscle bundles. And in that situation, I do find that Desmond can be quite helpful in highlighting the background ghost outline, so to speak, of degenerative muscle. So here's a beautifully oriented specimen. So in other areas, we did have a non-invasive component. So this is kind of a weird piece here, but showing you this for orientation wise, you can see these large, thick muscle bundles. It's almost essentially like a cystectomy, because you have LP, MP, vascular plexus, and these thick muscle bundles that are extensively involved by invasive urothelial carcinoma. And here you actually can see fat. So again, I don't even mention this. I don't even mention that this is, potentially worrisome for extravesicular and this, because you can have fat that comes up actually above the MP here. So again, I do not mention fat anywhere in the reports at all, whether it's the presence or invasion into the fat. Here's another example, and this is probably leaning into more typical degenerate. Shouldn't say degenerate. This is actually, to me, a beautifully oriented specimen still, but you can see these sweeping muscle infiltrative nests of essentially carving out and dissecting all the muscle bundles. And some of the tumor nests are actually, these irregular nests are actually invading out directly into the muscularis propria. So another, to me, probably straightforward example of muscularis propria invasive urothelial carcinoma. Here's another example where I think at low power, it's, you can see these, larger muscle bundles essentially being splayed by invasive urothelial carcinoma. But what I wanted to draw your attention to is what I call the 3/4 rule, because I think at least this is the typical scenario where you get cases like this, where you have tumor on this side going across and tumor on this side, but it's not actually in the muscle bundle. For me, when it's 3/4 the way around it, I call it MP invasion. I think that's actually a quite helpful tool. Here's an example of what I mean by the chewed up phenomenon. So if somebody were to show me just a high power picture of this, I would be very cautious on calling this MP invasion alone, without either looking at obviously at low power. I think on these at low power is actually probably more helpful than the high power, and you get yourself in trouble. Or if you're going to actually do a Desmond stain, you would actually see that there's actually a lot more degenerative tumor muscle bundles than you're appreciating. So this is what I called, I showed you the 3/4 rule before. This is what I call a chewed up phenomenon, where actually the muscle bundles are actually this is a huge nidus of muscularis propria in here that's just been completely chewed up and carved out. So all you're seeing these irregular strands. But this can be a real challenge as to whether this is hyperplastic muscularis mucosa or just normal MM muscularis mucosa and not MP. So that's where I think, looking at the entire case, cutting levels, knowing where you are sometimes can be quite helpful. In some cases, using Desmond immunohistochemistry can be a useful tool. So some cautionary notes before calling MP invasion. Again, knowing if it's helpful to know where you are in the bladder. You really want to ensure that you're not invasive into the hyperplastic muscularis mucosa. That's a real pitfall, and I would say probably a bigger pitfall than probably any issue. PT non-invasive versus PT1 can be challenging, but I see probably more overturns of diagnoses, and this is clinically quite relevant, because assuming we're not dealing with variant histology, and we'll talk about that in a couple of weeks, but just typical urothelial carcinoma, the minute you have T2 disease, you've essentially given the urologist a green light to essentially do either neoadjuvant or cystectomy, there are various, scenarios where you might do that either regardless, but it's a huge deal. So I have a very high threshold for calling MP invasion, and it essentially needs to be perfect, and it needs to be exclusive of some important pitfalls. But I actually, so there are, and I'll admit, I'll be the first to admit that when the concept of smoothulin, that antibody came out, I was a adopter. I thought it was actually kind of a nice tool, and I'll show you what the heck that stain is if you've not seen it. But there are some markers, smoothulin and vimentin, that can be used. In my recommendation, I actually don't find it helpful. Smoothulin is essentially a marker of muscular propria, but it too often stains hyperplastic MM, and I don't find that useful. And then the RECIP ISUP consensus conference on immuno, which was several years old now, they actually recommended against using any immunohistochemistry other than potentially Desmond to confirm that you're really dealing with muscle or something degenerative, to not use these in assessment of hyperplastic MM. And then another very, I would say, underappreciated pitfall is be careful of when you're dealing with the bladder diverticulum, and I'll explain what the heck I mean. So here's an example where, at low power, you might be concerned that this is a carve-up phenomenon, but this is actually all hyperplastic muscular mucosa in here, and the cystectomy specimen confirmed these. These are all irregular small nests, and if you happen to do a stain, they're individual little bundles. This is all stroma in here, and it's just all hyperplastic MM. So this is not MP invasion. Here's another example. And this one, the more typical one, has this sort of, you have these, haphazard, seemingly haphazard, that may or may not be there, tumor nests, but you often see a myxoid-like background as well with these muscle bundles. So here's another example of hyperplastic MM. And there are some examples where I can't tell. I'm not sure if it's hyperplastic MM or MP. In those cases, if I'm assuming I've done the various rule outs, and I'll show you what I mean about the diverticulum, I just say that I can't tell, or show it around, or send it out for consultation. You don't necessarily, to be a hero and call it one way or the other. And actually, and if I'm on the fence, sometimes I would say, cannot exclude or something like that. You're better off backing off than actually calling it if you're on the fence. But I think, really showing it around and getting some expert consultation for folks that have seen, lots and lots of these, I think it'd be quite helpful. This is hyperplastic MM without a doubt, no issues at all. So this is where I meant. So there's a non-invasive papillothelial carcinoma here, but I wanted to show you and highlight what the heck the smoothulin stain is. So diffuse strong staining is a nice internal control around the vessels. So in an MP situation, and this is hyperplastic MM, you get this fainter, weaker staining, and it's a lesser degree. So this would be like a 1+, and this would be a 2 or 3+ along the internal controls of the vessels. And then vimentin would actually show the inverse staining pattern for hyperplastic MM, where it's 3+ essentially in hyperplastic MM. And then MP would actually show the inverse. It would actually be diffuse strong smoothulin, and essentially weak negative vimentin. To me, there's way too much variability with that. It's not a 0, 3+. It's a 1 versus 2, and how the lab is titrated and this. There's a lot of issues with this. So I actually do not find this helpful at all. So I don't use this. So ticks, we talked about diverticulum. I think it's a really important thing before you're going to do a T2. You should probably check if it's looking a little funny, and I'll show you what I mean, to make sure you're not dealing with a tick, because staging wise, remember that there is no T2. It's actually not applicable in a diverticulum specimen. And I want to draw your attention to this because I think this is an underappreciated concept that essentially goes from T1 all the way to T3. There is no T2 in a true tick. If you're at the edge of a tick or something, that's a different scenario. So here was an example that was actually called, you can see these thick, semi-thick, I would say, muscle bundles. If you happen to do Desmond, you would actually see it's actually quite small in here. And you have these irregular, again, a nice cauterized tumor, which is what we get, but it's essentially all around the tumor. But this is, when you go down and look in the chart review, this is actually within a tick. And so this is actually not MP invasion. Here's an example at a diverticulectomy specimen here. So you can see at the edge of the tick, you have nice thick muscle bundles here. So in that concept, yes, theoretically, you could do that in here. But here at higher power, you can actually see you do have some smaller muscle bundles here. And so at this case, I would have staged this as PT1 because it's a urothelial carcinoma invading out into the lamina propria. But again, in a diverticulum, there is no T2. There's essentially T1 or T3, or 4, so to speak. But really, there is no T2. So this is just showing you that sometimes this is what you get TURBTs of this. So knowing whether you're in a divertic can be quite helpful. So that's T2. Now I'm going to talk about T3. So T3 is invasion of the perivesicular soft tissue beyond the fat invading in the fat beyond the muscular propria. And again, grossly, if you think you may see it out into it, then it would be a 3B, 3A would be microscopic. That's sometimes less relevant. Sometimes where, you know, and if in an ideal scenario, you lay this all out and you map it and it's beautifully oriented. And, you know, if you clearly are seeing it out into the muscle and the grosser happen to say, no, it's only a 3A, I actually will change it and do it as a 3B. There's just no way if you don't have a photograph. But sometimes, you know, you do your best, you know, somewhat pro-sector dependent. But if you can, ideally lay these out and just essentially map so where you kind of know where you are, especially for neoadjuvant. I'm not going to talk too much about neoadjuvant, but at least here in the States, we're seeing probably more than half of our bladder cancers coming up neoadjuvant. And this is a non-neoadjuvant case. But in a typical neoadjuvant setting, what you see is, you may think it's tumor. I would say flip a coin, because half the time it might be tumor, half the time it may not be tumor. Neoadjuvant bladder is really hard to do. So in those scenarios, I always tell my trainees and fellows to actually map it out, because if you don't find the tumor, you may need to go back and submit additional sections or the entire scar bed. So if you can, I think mapping is actually quite helpful. So here's a nice correlate. You can see this a full cross section of tumor, and it really at low power, essentially a couple slides to put through to confirm tumor, and you're essentially done. This is a 3B urothelial cancer that's essentially invaded through the MP out into the fat. That's a low power example. And even, but again, I'm a big fan of low power. I think you can probably do a lot of it on the glass correlate by that, but here's a nice, this happens to be a micropapillary urothelial carcinoma, lamina propria here, and essentially this tumor is essentially going all the way through, directly invading all the way through the MP out into the perivesicular adipose tissue. So this would be a 3B if it was identified grossly. In a case like this, where if the grosser happened to say, no, I found this was 3A, I might go back and check the gross myself or look at pictures, because to me, this would be a pretty obvious 3B. So that's a straightforward PT3 case. However, there are challenges that can occur. So here at low power, you can see this kind of myxoid, basaloid looking tumor, and you have some lymphoid aggregates, and the muscle bundle essentially stops right here. So the challenge is this a T2B outer wall, or did it actually breach and go out into the subserosal adipose tissue? And here, at least there are lymphoid aggregates, which may or may not help, but I essentially draw a line at the adjacent parallel level of the thickest muscle bundle. And if it's essentially parallel to that and essentially within it, I hold back. Or if I see fat, if I see actually a parallel to fat, in that case, I would theoretically bump that up into a higher stage, or to a 3A or 3B if it's grossly. So in this case, I thought this was a nice example of a 3B bladder cancer, so invasion out into the muscularis propria, but still contained. And in contrast, though, so on the lower right here, you can see this tumor bundle. So this is mucosal surface here. You have this nodule hint. And again, so much of this is low power. You see this irregular nodule in here, and that grossly this was also worrisome for it. But the muscle bundle actually, and you can see here, essentially stops right here. So even though it's sort of barely out into the fat, if you draw a line here, to me, this whole nidus is actually parallel to fat. And in this scenario, this is another an example where I actually think immuno can be helpful, because if you just look at this picture on the upper left and you think, oh, if you essentially either, well, I shouldn't say ignore the fat, but just don't look at any of the fat, and all you see is this, you wouldn't know necessarily where you are without using these other anatomical landmarks. But if you happen to actually do a Desmond in here and say, oh, that's just muscularis propria, it would be dead negative. That's just fibroplasia. So in that case, actually, Desmond is actually very, very helpful in this, because the Desmond would be all chewed up, and essentially on the other side, there would be no Desmond in here. Desmond doesn't stain hyperplastic fibroplasia. So Desmond immunohistochemistry can be helpful. So in this case, this was a 3B bladder cancer here. So PT4. So PT4 is direct invasion of either prostatic stroma, seminal vesicle in males, or uterus or vagina in females. 4A. 4B is pelvic wall or abdominal wall invasion. These are much less common. And again, I think the gross can be quite helpful. So here's an example of a full cross section that happened to be mapped, and you have tumor into the seminal vesicle in here. So this is direct invasion. It's at least close and worrisome off the gross here, but clearly this is a 3B. You have tumor nodule. And again, I should say clearly in the sense it's a non-neoadjuvant. If this was neoadjuvant, I would still describe it as a tumor-like nodule, but I've seen neoadjuvant cases, then this is all scar. So you have to be a little bit careful. But here you can actually see some residual tumor invading into the seminal vesicle of the prostate in here. So this is a T4A. And then I want to draw your attention to this because this is another common scenario I do see. So it comes in as prostate chips. So it's a TURBT's TURBP actually, I should say. And you have multiple fragments of invasive tumor nests of high-grade urothelial carcinoma. You do have some prostatic tissue in here, but clearly this is a papillothelial carcinoma, high-grade, invasive into muscular nest, but you do have background prostate tissue in here. So in a quick, you're going through this, if it's a TURP specimen, you say, well, you just showed me that T4 invasion into prostate is a T4A. I have seen numerous examples of cases where this TURP comes in and this is staged as T4A. And I think histologically, in isolation, it's absolutely legit. Really probably shouldn't be, quote unquote, staging biopsy or transurethral resection specimens, but I think that's absolutely legitimate to do that. However, what's important is to remember that there is actually a different staging system for the urethra. So for the urethra, T4A is actually just subepithelial invasion, and T1 is subepithelial invasion. T2 for urethral is invasion into the prostatic tissue in here. In contrast, though, so that's T2. So T1 subepithelial. So T1 is subepithelial, T2 is invading into the prostatic stroma, direct invasion from the prostatic urethral mucosa. In contrast, this is T4. This is what we're talking about in T4A, or you have a big tumor nodules within the bladder directly invading into the prostate or seminal vesicle, but here we're talking about prostate. So that case I showed you earlier was actually, and this is one where you probably need to pick up the phone and ask the urologist or check the imaging. They may know. They may say, oh, he or she may say there's a big goomba of tumor directly out invading into the prostate. So you're kind of done at that point. You know that it's probably T4 or T4A. But if it's a urethral specimen, then it's a different scenario. Would I stage any of this? Would I put those TT numbers in the report? Not necessarily, but I think it's how you sign the case out. I've seen these TURP specimens signed out as high-grade urothelial carcinoma involving prostatic tissue or involving fibromuscular and prostatic tissue. And somebody looking at the report quickly is on paper, that's a T4, and that's not necessarily the case. So in those cases, I sign out descriptively saying it's invading prostatic and fibromuscular stroma, see comment, and explain that if you don't know, then you sort of bounce it back on them and say, look, if this is a direct invasion scenario, that's T4. And if it's not, if it's truly subepithelial, then it's a T2 and they can correlate. But they'll usually know, but again, these path reports are essentially gold. They get passed around to various clinicians, oncologists, and not everybody has the other reports. I think it's sort of our job to sort of tie in the various reports. And before you're going to do some of these stages, I've kind of harped on this a little bit, is to do your best to really incorporate the clinical, the imaging as much as you can. Talk to your urologist if you can before, on a busy day. I know it can be a little bit challenging, but do your best with some of these staging things, because I think doing that and showing the cases around can be quite helpful as well. So with that, I ended it a little early. I will take questions.
Hi. Thank you, Dr. Sangway. That was a perfect treat and a perfect beginning to this memorial series. No one could have done better than this. Surely.
Thank you.
There are a couple of questions in the chat box, and
Sure.
I think Dr. Vishal and Dr. Manoj have asked that how is substaging of T1 relevant? Is it currently relevant to the clinician? That information?
I think it is, and I think at least on this thing, at least on the ISUP recommendations. Let me go back on this one. But yeah, I mean, I think it is actually quite relevant. And there's good data. I didn't talk about this too much in here, but there is actually good data. And actually, there's some data knowing where you are in the bladder, that some, if it's trigone tumor, because it's a quicker way to get to T2, that can actually be quite helpful to kind of know. But yes, this is one where I sort of preach and say, oh, you should definitely substage. Do I do it in every single case? We just had a case yesterday with my fellow, that one picture I showed, and I told her, I said, well, maybe. So, I mean, a quick and dirty way, you measure this and this and all that kind of stuff. But I know there's variability in how you do it in a busy practice. I think a very simple way, I mean, just could do it. If it's just a little bit, say it's a little bit. If it's a lot, say it's a lot. And if it's in between, you either can say nothing, that's an option, or maybe just say, indeterminate or intermediate. But I think that's actually really helpful in these cases I've shown. These just a pinch of little invasion, that's not the same thing as a deep extensive. Or if you're really worried that it's hyperplastic I can't rule out MP. If you just sign it out as T1, that doesn't help anyone. So
yeah. Couple of more questions are basically on use of how to distinguish muscular mucosa and muscular atrophy. I think we've already dealt with that. Someone has asked, Dr. Padmaja has asked me, how many deeper levels do you do before you really sort of sign out something
Ooh,
as
that's a great
a
question.
DTA in
Ah,
kind of
that's
thing?
awesome. That's a super good question. So, I am biased, and that's where I use cytomorphology. If it's a very, very high grade tumor and you have one slide, and it's a biopsy, sorry, or a TURBT, I almost always will not sign that. I routinely will order at least three. At least three levels. There are sometimes in our busy practice, my prior group, we'd always used to get three, but here sometimes at Stanford, we actually just get one. I'll just upfront cut additional levels because I would say more often than not, if it's a high grade tumor, it looks like it's about to pop. Your best stain is actually just H&E, so cutting levels. So frequently I will do levels.
Yeah, I agree with you, Dr. Sangway, that I think as pathologists, we should start substaging this, at least give it a try. I think
Sure.
most of us do a focal versus extensive kind of statement in the
Yes.
laminar
Yes.
process. So I think it's been pretty regular. Most of us would say it's focal invasion versus extensive. That does give the clinician a hang of how things are going to be. They can talk to the patients, and in a given scenario, say in a recurrent setting with a lot of CIs, the patient may be an early candidate for an early cystectomy in such
Sure.
cases, and that's important. Um, uh, um, on the ask whether you use the term indeterminate for muscular invasion.
Yes,
When
yeah.
do
So
you
same
use
thing,
that term?
indeterminate. Yeah, yeah. Same scenario that, if it's hyperplastic or, and sometimes I also use indeterminate if whether there's MP present. That's another scenario. We have a non-invasive or even a PTA or PT1, and you have a separate bundle. I'm not even sure that's muscle. They may want to know, at least in the States for AUA guidelines, they still go back within 3 months either way. But I use the indeterminate for the presence and or the depth of invasion. One other question that it's not on here, or maybe it's not on here, is you have a big, big tumor, right? And a grocer, they come to you and they say, look, do I need to put this whole thing in? And the answer is maybe. So I actually start with maybe half or three-quarter, do your best. Unlike the TERP specimens, where they think there's good data showing, benign BPH, you probably do, 8. Every lab is different of how much. I do end up because it's frequently happens is the cases where it's a 50 block case. Of course, it's block 49. That's where you find the MP invasion. So in those cases, if it's a large tumor, and if it's kind of, if it's a lower grade thing, you can sort of decide. Because even if you call a little invasion or you not see it, if it's a big tumor, they're going to probably go back either way. But if it's a high grade tumor and clinically they're kind of worrisome and you're not seeing invasion, I will do it in stepwise. Essentially, once you've gone to T2, then you're effectively done. I guess the next, you say, well, how much further can you get? That's the other question. I said, look, I have a 20 block, it would be 20 blocks. And then, in 5 blocks, you have MP invasion. Do I really need to put the next 15 in? It's controversial. Staging wise, no, but the other issue is neuroendocrine differentiation. Finding other variant histologies actually can be quite helpful. So in those cases, I would say, unfortunately, I love bladders. So I tend to I'm happy to look at glass, but I do tend to put in almost all the tumor in all my cases.
Yeah. There is a question on stock invasion versus base invasion.
Yes,
Because
yes.
stock invasion don't do better than base invasion. So I think,
Yeah,
yeah.
there's one study I didn't, again, just for time purposes, that looked at stock just like in GI. It's out of University of Washington. Maria Chetrikova had a beautiful study about stock versus things like that. I think there's other studies that have shown something similar, but I don't use this limited to GI like stock thing. I essentially just do LP or non-LP. But at least there's some studies showing that if it's just at the tip, they do better than they do at the base. But I don't think
Another
that
point for
concept that stock is well recognized, so I don't use it.
another point for discussion, Dr. Sangway, is that many a times at many centers, at least in India, I can tell you that sometimes the tissue is too fragmented and too cauterized, and that creates the maximum problem in POB. I think the basic problem starts from very badly cauterized samples, and that's what generally the problems which we face in our practice. That's a comment. Uh, Personally, I would like to ask you one question, Dr. Sangway. When you go to multidisciplinary meetings and tumor boards, the radiologists would be there and they would probably say this looks like Viride 5 and this is the MR is it's almost sure. And sometimes they would do a TURBT and the muscle is not there, but the radiologist is sure. How do you tackle these cases in MDT? Do you have a consensus that the radiologist is confident and we are not seeing a muscle, something like that? Do you have a discussion?
Yeah, no, there's been cases where they say, I saw, I mean, I looked at it and I swear there was, did you, who grossed it? Did you throw it away? Or I swear they saw it. I mean, you do the best you can. And, they're almost taking pictures, so to speak, and cystoscopically, either the presence of the muscle. I've also had that scenario where they say, look, it's a, non-invasive tumor, but I know I got muscle and you don't have it. So, it is what it is. But clinically, I think it's if they think it's something, they may proceed either way.
So Dr. Padmaja is asking another question, whether do you recommend putting deep muscle in the same container or separate container? I think most of the practice sends it in separate containers.
Correct. Yeah, they should technically, separately submit it. For staging purpose, when I'm doing my synoptics, though, I will actually do one synoptic for the whole case. The other thing that actually, and I didn't talk about that too much, is on the these separately submitted. You talked about that. So you have a part A, which has invasion. So let's just say there's PT1 invasion, may or may not have muscle. But in part B, which is the deep specimen, you get muscle, and you have this cauterized thing, right? Because they've already cauterized the base or whatever. Whatever that is doesn't matter. I see people do stains, levels, and all that stuff. All they care is if they got the muscle. So whatever that cauterized atypical epithelium kind of stuff, none of that really matters. All that really matters is did you actually get the muscle or not?
There is another point of confusion raised by Dr. Sanana, who says that when you have two separate containers, and the second is the deeper container, which shows some tumor. It's a kind of a carryover or a contaminant in the second container, or a tumor which has spilled over into the second container, but there is no muscle in that. And when you give a report saying that the deep muscle tissue shows presence of tumor, but there is no muscle somewhere, and that can add to a lot of confusion to the clinician. So
Correct.
do you encounter such situations?
Yeah, I do see that. And just do your best to be very clear in the report. Because the minute you just, these are quick reports. Somebody's looking and say, the deep muscle tumor present. Oh, okay, it's involved. And detached fragment, something like that, or see comment. Get them to read the comment as much as possible on those things rather than just, reporting it out.
I think we were pretty much done with the questions, and it has been wonderful listening to you, Dr. Sambit.
Great.
Dr. Bedi and Anandi?
Yes.
There are no more questions.
Yes, it seems so. And we could feel Sambit's spirit around.
Yes.
We thank Ma'am Siva Mohanty. She is in the audience, and she has thanked for remembering her brother's memories. She's Sambit's sister. She's in the audience.
Yeah. We thank her for being here, and we share their sorrow. Totally share it.
So with this, we can end. The next one is on 18, and I'll share the on the screen the QR code for the next session.
Yeah.
Yes.
We can circulate that on WhatsApp and
yes.
Dr. Sangha, it's been an absolute delight listening to you.
Yes.
Great. No problem. Thank you. Thank you for the invitation.
We can close the meeting?
Yes. Yeah. So I'll circulate it. So thank you very much, Dr. Ankur. I mean, it was a perfect start. And thank you, Dr. Santosh. And thank you, Anandi, for being there.
Thank you, Anandi.
Absolutely, and coordinating, yes.
Thank you, Anandi.
I mean, you did a lot. I'll say I just started and you took, like you were with Sambit in the conference, here also your role was in the background, but really great.
Thank you. And thank you, Dr. Sangoi. Yeah, it was a great lecture and a great session. And we look forward to your second session also.
Yeah. Great.
Thank you. So I'm ending the session. The recording of this will be available on YouTube, and it's already there. So
thank you.
I'll share the link.
Good day to you, Uncle.
Thanks.
Your day begins.
Bye-bye.
Good night.
Okay.